Something wrong with this. Let's see. Working on a capsule episode. Oh, there we go. All right. Ah, there we go. All right. So we're just gonna go over some prep work for the episode I'm doing on capsules. A lot of times it's probably not super clear all the different things that are going on with the capsule that develops around an implant. We end up in the run up to an episode I'm doing, we've looked at multiple papers throughout different decades. The first implants were placed basically in 1962 in this country, in the United States, by Cronin and Giroux. But in the literature, when you look things up, which I have to look something up now, so I'm just going to open up my computer. I like to go back and read some of the older papers and review the literature when I can about capsules, capsule formation, what was the thought process when they were trying to review their experiences with device placement. And there ends up being a lot of discussion, certainly on social media, about in-block capsulectomy, complete capsulectomies, intact capsulectomies. Do you need to perform a capsulectomy? So if you have questions, just put them in the chat, and I'll answer them as they come in. Probably not all that busy here on a Saturday morning, but this is when work gets done a lot of times. A lot of glare off one of my lights. So we're going to look up some articles and go through them. I really enjoy one of the articles from the 80s. I'll pull it up and go through it. have so many articles saved. If you haven't, I did a whole series of episodes about biomaterials, so what was injected for augmentation. It's crazy what was injected for augmentation. So I did a whole series of those. You can go back and find them on my YouTube channels. I put them both. Put out the videos on both. So it's wild. They started with paraffin, which is not liquid at room temperature. It has to be heated to become liquid, and then it can be drawn up and injected, but it's really causes tons of problems with long-term granuloma formation. One of my favorite papers is written, it's published, it's written by Mary McGrath and published in October of 1984. I enjoy the paper. It's a good summary of the literature, and it cites a bunch of papers written by Brownstein and Owsley, Baker, Cronin, Hips, Kay, Pickering, Trutman, Wharton. It's a really well-written paper too. One of the topics in the paper is concerns about breast implants. Concerns about breast implants include the physical, biochemical, and immunologic responses to a silicone-formed body, which may be expressed as a contracting capsule or potential for the induction of neoplasia. It is interesting. Goes on to say the surrounding tissue generally reacts with a mild transitory inflammatory response without evidence of chronic inflammation associated with toxicity or the antibody formation and plasma cell infiltration associated with an immune response. Well, that was October of 1994, and I can assure you we now have evidence to the contrary. And that's probably a good jumping off point. That's one of the main things that I'm interested in highlighting and explaining. So when we're developing this episode, which I'm going to film another piece of here after I get done with this prep, is the capsule that forms around the breast implant starts, developing, right away, and the response is really what's different. And in this paper it says it's an inert foreign body, which it's not, obviously. Anything that's stuck in your body is not recognized as self, because you don't we have genetically from each parent we get what's called a haplotype. So you get part of your genetics from one parent, part from the other parent, and the mixture, especially in what's called the HLA, human leukocyte antigens, that creates the polymorphism that allows you to recognize different antigens. And it's that recognition that helps your immune system tell foreign from self. And of course, a device is foreign, so. Also goes on in this paper to talk about the response that you have to different types of biomaterials like liquid silicone, the silicone elastomer shell. Um, Once again, this is in the 80s, and there were some limitations certainly there. But once we're talking about capsules and capsular contractures, and our body normally basically tries to wall all that off to protect us. That's the response. And I just had a call yesterday from a patient who was developing more of a capsular contracture, and they were concerned about that. And should they have surgery that was already scheduled, moved up earlier, and like all devices have, a capsule formed around them. And then since we're talking about a breast implant, like there's this, to me, like era where they were behind the breast predominantly when they were first placed in the 60s and 70s. And then because there were so many problems with capsular contracture, they ended up putting those behind the muscle, and the thought was that actually reduced the rate of capsular contracture. I just think it made it harder for the examiners and the patients, so I don't know that it actually changed the rate of anything. I think it's pretty subjective, meaning like the patient has to tell you, you have to examine the patient, and many times it's very hard to gauge the severity of something, even, on the multiple thousands that I've examined. And also, in this paper, it talks about two leading causes of problems with capsular contracture, which are infection and hematoma. So those obviously are still to this day the case. Problem is, like, how do we define infection? When is it infected? I published a big paper last year looking at just biofilm in general. Biofilm is, think of it like a small amount of contamination. Frank infections are usually graded at 100,000 colonies per high power field, looking through a microscope. That was all done in the 50s with urinary tract infection as the infection model. I don't even know that I have this paper in my other notes, but I'm going to put it in there. It's such a good paper. So, I'm going to go out. Oops. Go back on it. Is it too early for everybody? Nobody's asking any questions here. That's all right. That's all right. Not a shock. Not a shock. Got to import this into my Remarkable so I can keep track of this. Yes, go ahead. How do you? I don't know how to pronounce your name. Izzy? Liz? Yeah, go ahead and ask a question. It's fine. I'm just preparing to talk. Yeah, I mean, I'm preparing a whole podcast just about capsulectomy to help raise awareness to why a capsulectomy should be discussed and why it's important. So for many years, capsulectomy was done from an oncologic standpoint because cancers can um, develop in those. So, and there's literature. Actually, you can go to either. I guess we should post all these on my website. But I wrote a paper last year and published it that 29% have bacterial contamination when we explant them and do full capsulectomies, which I do on every case. And so, if you don't explant somebody and they have that underlying contamination, then they can still have symptoms. If you were to do, and I'm saying, I do a complete capsulectomy on everyone. It's not dangerous, which is said, routinely. That's not a problem. You're not going to injure people or cause problems with the lung or, and many times because I take out so many that have problems with inflammation and infection and swelling, they come out actually, some of them very easily. And so the harder ones certainly are ones that are more like a toilet paper, or like really thin. So I don't advocate for partial capsulectomy. So I would not recommend that. That's not something I would do. Oh yeah, that would be good. Of course. Got to see if I can wake up my patients from other places around the world, since you seem to be the only person paying attention this morning. We'll see. We'll see who else can come on board here. It's all right. So go to my website, or if you want to go to my YouTube channel, and in the links you'll find the paper about biofilm. You can share it with the doctor. There's plenty of work that should make that obvious. All right, let me see this on the paper here. Yeah, I like that paper. I gotta include more of that in there. My Got to answer a patient question here on my patient portal really quick. Let's see if I can get it to load. Oh, we get to welcome Lisa, another person awake this morning. That's good. Welcome, Lisa. I said I would start doing this more frequently, but I think I work too much and too early for most people, so it's not probably as beneficial as I thought it would be for everybody. Hello. Just answering a patient question here on medical record. We identified a bunch of mold toxins on a toxicity test and created a treatment plan. They just had a question about it. So we'll resume our discussion here in a minute. All right. All right. Ouch. Smashed my elbow. All right. Lisa, do you have a question? All right. No. Okay. All right. I'm going to end the stream here.